All right, let's continue to talk about treatment for acute MIs. We've talked about medications. Now let's talk about really what's going to fix it, because the best thing we can do is to go in there and open up that coronary artery. So restoring blood flow is what we need. We are going to do what's called a PCI, percutaneous coronary intervention. Please make a note that your book does call this a PCR, percutaneous coronary revascularization, instead of PCI, but PCI seems to be what I see most frequently used, so I'm going with PCI. It means we're going to get in there. Evidence says the best thing we can do is get them to the cath lab and go open up this artery. And actually, we want to do it within 30 minutes. So we have to recognize that something's going on, look at their signs and symptoms, get an EKG, get a troponin, let that healthcare provider know, and get them to the cath lab. Because the sooner we open it up, the less damage it is in their heart. Now, if for some reason you can't get them to the cath lab because you live in Timbuktu, New Mexico, or Oklahoma, or Colorado, all those places that come here, and you can't get here, your local facility can give you a clot buster. Now, what do? We actually fly people in. But if it's in the middle of a snowstorm, we've got winds blowing 80 miles an hour, we can't fly people in, so they may be given a clot buster. I'm not going to talk about giving a clot buster here and everything that you have to watch for, because that fits with neuro content, where that is the treatment for stroke. So that's where I let that live. So when we go into the cath lab, they're going to inject dye into these coronary arteries. You do have some pre and post cath fast facts that you need to look at and review those, so that you know what's going on. If it's a scheduled heart cath, they may have them NPO for a certain amount of time before the procedure. But they go in there and they're going to inject dye. So you can see where this arrow is. We have a blockage, and they will put a catheter in there and blow up the balloon. That is the angioplasty, or the what's called percutaneous transluminal coronary angioplasty, PTCA. Most of the time that is actually now inserting a stent, a metal device that stays in that artery to hold it open, and it stays there forever. So this is the treatment for STEMI. For non-STEMI patients who are unstable, they will go to the cath lab and can have this done as well. Complications from these procedures: we can have vascular complications. They will poke them in the femoral artery, so we can have bleeding, hematoma, retroperitoneal bleeding. So you may see a hematoma at the site. So you want to check that site when they come back. We check it every 15 minutes for an hour, then every 30 minutes for an hour, and then every hour. Follow your protocol. We're checking the site. It might be a little bruised. I might have a little drop of blood. No big deal, but I expect it to be soft. I check distal circulation. So if it's in my femoral, I'm going to check my pedal posterior tib pulses to make sure I still have pulses and blood flow going to that leg. If they develop a hematoma, I'm going to hold pressure on it. If they have a hematoma, I need to be sure and mark it, because if they have a hematoma, they're going to bleed at the site. They could have what's called a retroperitoneal bleed, which means they are bleeding in their abdomen. Much more difficult to identify. They can have back pain. They will have tachycardia. At some point, their blood pressure is going to go down, but they've bled enough for their blood pressure to go down. Abdominal distension is a tricky one. Most patients, it's hard to see because they have a lot of adipose tissue in their abdomen, so their abdomens are already kind of big. But if they are thin, you may see abdominal distension, but certainly you will have tachycardia. You could have a change in blood pressure. You would also see decreased urine output because they are bleeding. We could have a complication of this stent re-stenosing after they get back. If a patient goes to the cath lab and they get a stent, I would not expect them to come back and develop chest pain or discomfort. That is an unexpected finding. I would want to get an EKG, maybe get a troponin, treat the patient, and call my healthcare provider. That is not an expected finding for a PCI. When they come back, I want to monitor them. I would not expect to find new ST segment elevation either. That would be an unexpected finding. I expect that EKG to get better. Post-heart cath, some tachycardia, that can mean a whole bunch of different things. Maybe they're in a little bit of pain because they're having to be on a specific amount of bed rest time, and that doesn't feel really good. They got to keep that leg straight. So they might be a little tachycardic, but if they've got tachycardia unrelated to anything else, that would be concerning. I would expect their vital signs to be stable as well. So you can think about expected and unexpected findings. These patients will be given heparin in the cath lab and either be on a heparin drip or be given clopidogrel or ticagrelor, so they are at risk for bleeding. So we do need to monitor them for that. Tell them to reach down, hold pressure if they have to sneeze, cough, or laugh on that side. Notify us if they start to bleed. If they are bleeding, you put your hands in it and you hold pressure on that, because somebody can bleed to death in 2 minutes in a femoral site. All right, you got some really good notes. The other thing we need to think about, and this goes to the fact about them being NPO, is we are giving them dye. And when we give contrast media or contrast dye, the patients are at risk for developing contrast-induced acute kidney injury. And the way we prevent that is to hydrate our patients before and after they go to the cath lab. So I would expect to have an increased rate of IV fluid after they come back. They can certainly drink fluids as well. And really, to have somebody NPO for 8 hours before a cath is really not what evidence is showing anymore. They can be NPO shorter periods of time. But I will tell you, we still have local physicians who are making them NPO for a long time. But if they are going to the cath lab and they're going to get dye, you do need to be concerned and think about what you need to do to prevent acute contrast-induced acute kidney injury, and that is actually to provide them with some hydration. All right, so some patients may not be able to be fixed in the cath lab and they need to have surgery, so they need to have coronary artery bypass surgery where they go in and do an incision. So these patients are going to go to surgery. Sometimes they come in the morning of surgery. Sometimes they're going to be sitting in a cardiac intensive care unit. They could just be on the floor when they go to surgery. They certainly come to the ICU surgical intensive care afterwards. They will be in this surgical intensive care usually between 1 to 2 days. Post-op, I have seen patients go to the floor on post-op day 1. I've also seen them stay. The longer they stay in the ICU, the more complications that they've had. Typically, these patients are going home in 5 days. An uncomplicated acute MI who goes to the cath lab, gets open, doesn't have any issues in Amarillo is going home in about 48 hours. So there's something for you. So let's talk a little bit about what this post-surgical bypass patient's going to look like. They're going to have lots of tubes, lines, and drains. They're going to be on a ventilator. So this is a good picture. I call this the CABG man. Borrowed it from a textbook. This diagram does have them having a nasogastric tube, an NG tube. I will tell you we don't do that. Number one, we do OG tubes all the time, not NG tubes. So if you're intubated, you'll have an OG tube so that we can feed you and or decompress your stomach. These post-bypass patients do not. They will have a central line of some sort. They'll be hooked up to the EKG. They'll have a midline incision. They might have epicardial pacing wires. They will have chest tubes. They will have pleural chest tubes as well as mediastinal chest tubes. They have mediastinal chest tubes to drain fluid from around their heart so they do not develop cardiac tamponade. Cardiac tamponade means there's fluid around the heart that's squeezing your heart, and the signs of cardiac tamponade are tachycardia, low blood pressure, JVD, and muffled heart sounds. So I just covered my mouth, muffled heart sounds. So having a clot in my mediastinal tube after surgery, not allowing that blood to drain, could cause cardiac tamponade. Patients can have cardiac tamponade for other reasons, such as trauma, or it could be spontaneous. So the signs and symptoms are the same. So cardiac tamponade is blood in the pericardial sac that squishes the heart. So the heart's being squished, which means as the heart tries to pump blood out and have cardiac output coming out, it can't. So my blood pressure goes down. My heart rate goes up because my blood pressure's down. I develop JVD because that blood is in a big circle and I'm having difficulty getting blood back into the right side of my heart, and it backs up and I get JVD and then get muffled heart sounds because I'm listening through all that fluid. That is an emergency, and we need to check these mediastinal tubes and make sure that we don't have clots in them. So your patient's going to come to the ICU. They may have an arterial line, which is a catheter in their artery to get continuous blood pressure monitoring and to draw IBGs. We will talk about hemodynamic monitoring and arterial lines in perfusion part 2. They'll have a urinary catheter. The incisions on their legs can usually are small little incisions, one at the bottom, one right about the knee, and maybe one up on the thigh. So it's important for these patients, what they do in the unit is they're going to wake up, breathe on their own. We'll get them off the ventilator. We need to stabilize their blood pressure. Sometimes their blood pressures, if they're going to be anything, they're usually low. So we're going to give them a vasoactive or a vasoconstrictor like epinephrine. They could be hypertensive, so we would use something like nitroglycerin for that. So they could be on IV medications. They could be on inotropes, which help improve contractility, which is why they're hanging out in the unit. We need to get them up. They need to walk. They need to turn. They need to cough. They need to do deep breathing. They need to do incentive spirometer. They need to take that IS home and use it at home. They need to walk at home. We need to do discharge teaching. They're going to have wounds that they need to just wash, pat dry. Don't be putting things on them. Your notes have some basic post-bypass discharge teaching that we're going to give. They're not going to do any driving until they're released by the surgeon, which is usually 4 weeks. And patients have a hard time with this. So when I would talk to patients about post-bypass care and going home, I would say, let me tell you why I don't drive. What if you were involved in a motor vehicle crash and you got hit in the chest with a steering wheel or an airbag, and it would just break your chest back open? Because to do surgery on their heart, we had to cut the ribs off from their sternum. We've put them back on and we've wired them. And when I say that to people, they're like, oh, then they don't want to drive. No heavy lifting until they've been released. And then you basically have some basic information on when to seek help. If you have a fever greater than 100.4, you've got difficulty breathing, you've got chest pain, lightheaded, dizziness, rapid or slow heart rate, worsening pain in the chest, redness, bleeding, or pulse draining from anything, increased swelling of your legs. Their legs are going to want to swell, so they need to keep their legs elevated. Tenderness, redness of an extremity, they need to notify their healthcare provider. We may be using TED hose, and if we are, they need to wear those when they go home, and they need to do things like walk a lot because we don't need for them to develop a VTE and then have a pulmonary embolism. And we need to refer these guys to cardiac rehab. Complications post-surgery, they can have dysrhythmias, both atrial and ventricular. They could have another MI. They could have a stroke. They can have pericarditis, pericardial effusion. That's a cardiac tamponade that's not trying to kill you, because cardiac tamponade's trying to kill you. And some bleeding. All right, so cardiac rehab is important for these patients, and what cardiac rehab is, this is important for your bypass patient, your MI patient, your unstable angina patient. They all need to be referred to cardiac rehab. It's interprofessional program that promotes recovery, maximizes functional performance, develops independence and self-management for patients recovering from an MI, cardiac surgery, or a PCI. So they learn to exercise. They go in and walk on a treadmill. They talk to a dietitian. They talk to a pharmacist. They talk about how to reduce their stress, because stress is a risk factor for CAD. So we need to be sure that we're talking to them about that. They will assess them for depression, because that can happen after MI, and that's important that we assess them for that. So it's a really good program, and fundamentally all patients should be referred to that. All right, so complications of MI are dysrhythmias, which can happen. Heart failure, cardiogenic shock, dysrhythmias, those are the three most important ones. Rupture portion of the heart, probably means that they may not survive. Could be the interventricular wall. They could have a septal defect. If they rupture a papillary muscle, they will develop a new murmur, and so that would be concerning. Pericarditis is inflammation, which hurts worse when they take a deep breath and move around. That is can happen after MI. And their infarction could get bigger, or they could have a reoccurrence. So you can just kind of think about what those means. Lifestyle, we've really kind of talked about everything for females. Sometimes they have delayed diagnosis and treatment because of their signs and symptoms, and your older adults may not seek treatment. All right, let's hit our last topic of health promotion strategies. So health promotion and maintenance, risk factor reductions, NCLEX client need categories. I put a big star on this because this is probably some teaching that you need to do. So they're going to have aspirin on arrival and continue at discharge. They're going to be on antiplatelet therapy, so probably ticagrelor or clopidogrel. So Brilinta or Plavix are the trade names for that. They're going to have a statin started as soon as possible and continue at discharge. We do need to evaluate their left ventricular ejection fraction, which may be done in the hospital or could be done at the physician's office. It's done in an echocardiogram and also in the cath lab. They will be prescribed beta blockers, but long-term use of beta blockers is being safe for those patients who have heart failure. If their ejection fraction is less than 40%, they will be started on an ACE inhibitor. They need to be referred to cardiac rehab. We need to do healthy lifestyle changes, and we need to think about those psychosocial considerations of anxiety, depression, and stress. And we also need to think about those for their families. Thanks.